My name is Peter Stanton. I'm the publisher of the Worcester Business Journal. It's my pleasure to welcome you here this morning to our fourth annual breakfast series on the state of the state in healthcare. Events like this are only possible when we get the support of the community, and that support comes from our presenting sponsors, Fallon Health and Reliant Medical Group, and our event supporters, the HRMA, the Human Resources Management Association of Central Mass, Conover and Gould Strategic Communications, and our media partners this year are Charter Channel 3. It's my pleasure to introduce our keynote speaker, Delia Vetter from EMC, who's their Senior Director of Benefits and Programs. Since joining EMC in 1994, Delia has helped build a nationally recognized comprehensive benefits program at the company. Focused on cost effectiveness, innovation technologies, and health programs, the plan uses technology tools to manage employees' healthcare and healthcare dollars and to effect behavior modifications to the tune of millions of dollars in savings for EMC and its employees over the last decade. Under Delia's leadership, EMC was the first employer to provide an employer-sponsored e-personal health record, and the company's been recognized with the 2013 Lifetime Achievement Award and 6 Best Practice Awards from the New England Employees Benefits Council, as well as numerous other national and regional recognitions, many of which are listed in the program. Delia serves on several boards of trustees, including the Milford Regional Medical Center, the Mass Hospital Association, New England Health Institute, New England Employees Benefits Council, and she is on the Advisory Council for the Pioneer Health Institute. Delia is a sought-after healthcare expert, and this morning we're going to be the beneficiaries of her expertise as her talk is on developing your company's healthcare strategy. Delia, the podium is all yours.
Thank you. That was a great introduction. Well, everyone, I guess we're all here because we all love healthcare, right? I know I do, and I've been in healthcare or in benefits, which today is really healthcare, for almost 30 years, and 21 of those years at EMC. So I've had an opportunity, just like many of you, to experience many different changes in the healthcare environment. And one of the things that's exciting today is that it's different. It's different than it was 10 years ago, and it's going to be different in the next 10 years and 10 years after that. And the opportunity that we all have collectively to make that change, I hope you all realize, is really important to developing, the next era of healthcare. And so, it's interesting, when I titled my presentation, How We Got to Now. And the next 20 minutes, I'm going to focus on our journey over the past 14 years of how we got to now. But I'll tell you how I came up with the title, How We Got to Now. Thinking about, what should be the title for my presentation. And I recently read a book. It was called How We Got to Now by Stephen Johnson. And it's the 6 innovations that make the modern world. Although it's not about healthcare, but it does provoke thought in what you can do, what you do today that you think might be insignificant, how 1,000 innovations on top of that will create yet the next modern world. So what do you think that the 6 innovations that created the modern world are? Glass, cold, clean, light, time, and sound, okay? Nothing that you would think of, okay? But each one of those is what's created the modern world today. And so as I think about what we've done as an organization and what you might be thinking about doing is going to create the next modern world of healthcare within the healthcare community. So the strategy for us was the year 2000. In 2000, if you remember, the healthcare cost crisis, lots was going on. The bust of the .com and many things were just happening around us. And we needed a different approach to managing costs. And we really thought about at the time, our costs were increasing double digits. We had great relationships with our partners, with our vendors, with our health plans, but employees were driving cost. And one of the things that we were very sheltered from was understanding the healthcare marketplace, okay? So the first step in our 6-step program here to creating the next modern world for us, or to getting till now, was to get out of our office and go out and learn about the healthcare marketplace. So many of us, and we still do today to some degree, but all of us historically have really relied on our consulting partners and our health plans to guide us and give us information and insight into the healthcare marketplace. And that's absolutely a great thing to do, and they are very insightful and they have a whole different perspective, and so both as a resource is absolutely critical to building your strategy. But what you need to do is to go out and learn on your own. And so at EMC, we were given the opportunity to go out to the healthcare marketplace and just learn about the challenges at the provider level, at the hospital level, other employers, the political arena, the healthcare policy, because we were very sheltered, and while we were thinking about how do we design benefit programs, we weren't thinking about what's driving, what's the root cause of driving healthcare cost. So improving our knowledge of the healthcare marketplace was step one. So now, when you do that, and you come back in, and you're sitting with your leadership, and you're talking about something different than how do we design a health plan, but you're talking about as an industry expert, it gives you credibility. So now you're building credibility with your leadership because you're talking about something that they might be reading in the Wall Street Journal or on the Globe, right? And then you go out and you meet all of these experts. Now you created a network, right? And so, as you're thinking about developing your strategy and bringing credibility to what you're about to propose to your senior leadership, bring in those friends that you made, right? Because they just add credibility, again, to what you're currently stating. So it's all about it's branding yourself, your credibility, and bringing in knowledge from the healthcare marketplace and bringing in the right experts to help you sell that vision. And then, of course, thinking long term, because it's easy to think, well, what should we do next year for healthcare? We do a little tweaks, but that doesn't work, right? Because healthcare costs continue to increase in the market, and it's very dynamic and it's very fragmented, and there's so many things going on. You really need to think about something in a very long term. So that's what we did. We thought about a strategy in the long term. We looked 5 years out. And then within that strategy, the consumer is at the center of that strategy because it's all about them, right? Healthcare cost, the equation for healthcare cost is pretty simple. It's unit price times utilization, right? That's it. And you can impact unit price by negotiating and so forth. And utilization is a little bit more difficult to manage, but you can do that as well through education. So the consumer is driving costs in regards to their lifestyle behaviors as well as utilization. So that's the other thing that we thought about as we develop our strategy, is consumers have to be at the center of it. And then develop partnerships and collaborations. So we were very successful at doing that. So prior to 2000, we looked at our health plans as a vendor, right? When we started to talk about and develop our strategy, it's really a partnership and collaboration, right? You want your health plan to be part of your strategy, to help you develop your strategy, to give you the insights, to provide you with a path. Maybe it's a different path than what you're thinking of taking, or if you're thinking about taking a different path, that they can support that path. So that collaboration is extremely important in those partnerships. So we moved from vendor to partners, and everyone is our partner. And then optimize data and technology. So in 2000, data today is such a used terminology, but back in 2000, when you talked about data, people didn't really understand what they could do with data. There had been so many failures with data in the data warehouse environment because we couldn't understand how we could optimize that data and leverage the data. So optimizing data and technology and integrating both to drive the right behaviors and to drive the right success. And then the last one is bottom-up approach, right? So all of us here that are kind of in management or leading a strategy, you never want the CEO or your boss or finance to say, look, you have to shave $20 million from the healthcare, because now you're reacting and you're doing things that are not long-term. You're focus on quick actions to save that 20 million. So driving a strategy from the bottom up where you're bringing the problem to your leadership. And at EMC, that's exactly what we did. We brought the problem to the chairman of the board. That's where we started, and began the education process all the way through. So driving the strategy bottom up, because it gives you much more leverage to think about and put together a comprehensive strategy versus just reacting. And so for us, as you know, you can't improve what you can't measure. So when we developed our strategy, there were a few components that we needed to include. One, which was data, understanding the health of your population. And we had very fragmented data points. We had many health plans throughout the US. I think we had 30, and very fragmented data points. And we needed to bring in data together so that we could look at it, analyze the data, and look at it much more collectively, and then develop our approach based on data. We also, at the time, had very arbitrary wellness programs. They weren't really delivered from HR. They were delivered from the line organizations, and we couldn't measure them because there was no way to measure the success of the programs because we didn't have data tied to the programs. And then, of course, we had a very limited knowledge of the healthcare delivery system and the economic environment and healthcare policy. And so we lacked a very unified approach to drive business results. So developing a strategy is driving business results for your company. And it's the sustainability of your company is based on those business results and getting everyone involved. So employees are also part of driving sustainability and business results. In developing a program, so now you've gone out to the marketplace, you've gathered your knowledge, you understand that you want a long-term vision, you know that some of the basics are you need data and technology to drive your strategy and to complement your strategy. Then there's some guiding principles that you have to think about. And for us, the guiding principles for our strategy was to maintain competitive programs. So, and that's why it was important to us to not shift costs to employees, because we in the tech industry really need to be competitive because we're a multinational company, and then within the United States we're competing with the Googles and the Amazons and so forth. So maintaining a competitive program is important, and offering choice because we know that employees like choice. Distribute the cost more equitably to minimize the impact to the majority. So we looked at, in developing the strategy, of changing copays, but our strategy wasn't based on changing copays, but we needed to align with what the marketplace was doing. So we did that once, and that was in 2005, and then we didn't do it again. But we wanted to make sure that the costs were distributed equitably. Promote consumerism. That was extremely important to help employees understand that they're part of what creates the healthcare environment of today, and help them to understand the healthcare environment. And then, of course, that we were, as a company, going to influence the healthcare marketplace by getting involved in organizations in the industry. So how do you do that? So now you have your guiding principles, and how do you drive it from the bottom up? Well, so data becomes important. So understanding your cost driver is key to developing your strategy. So for us, back in 2000, we clearly understood that 15% of our population was driving 75% of the cost. So there's your opportunity. So you need to stratify your population, working with your health plans, working with your consulting partners, stratify the population so that when you're sitting with your leadership and talking about why we need to take a different approach, you have the data available. And this, for us, became a very powerful slide. And so you're sitting with your leadership, and they said, okay, well, this is all great, but why? Because you're asking for investment. You need to invest in data and technologies and programs. And they'll ask, well, why should I? What's the return on investment? And what I always say is, what's the cost of doing nothing? So doing the analysis and looking at the cost of doing nothing would mean that costs would double in 5 years. There's your ROI. Because every finance organization wants that ROI right up front. They want to know the numbers. But I have to look at it much more long term. And the cost of doing nothing for us was doubling cost. And it's not just doubling cost for the company, it's doubling cost for our employees as well. Because employees pay a portion of that in the form of copays, deductibles, as well as employee contributions. And that's a really important factor, because when you're educating your employees and when you're rolling out a strategy, they need to understand that they're part of that problem as well, and then they can be part of that solution, and that everyone collectively doing the right things and being good consumers and smart consumers and changing lifestyle, that it contributes to the bottom line. One of the aha moments for our employees was when we developed our strategy and we rolled it out. And we rolled it out as a 5-year plan, right? So that's absolutely important for your population to understand this isn't a one-time thing, this is a 5-year plan. And we held meetings throughout EMC. I think we covered probably about 80% of employees. And as I mentioned, we started from the top, the chairman of the board, to the CEO, to EVPs, to VPs, and we went all the way down to employees, and we educated them about the healthcare marketplace. We went out, we collected the data, and then we came back in, we educated them so that they could understand what the next 5 years would look like and why it would look the way that we were describing it. So education is key, because you need the education to your leadership so that you can get support, because when you get down to the employee population, they're not very nice. When you're standing there and you're telling and you need that support. And so gaining support from the top down is important. And so for our employees, when we held meetings and we talked about, so what do you think healthcare cost? Well, I don't know, $5, because that's what I pay, right? And it's not $5, it's say $100. And who do you think pays that bill? Insurance company, they got lots of money, right? We've all heard this. The aha moment is when you say, it's not the insurance company. It's not the Blues or the Harvards or the Tufts or the Fallons, okay? Because in a large organization like we are at EMC, we are self-insured. And that's EMC's money, that is shareholder money, that is your money that's paying for this bill. So it's not, and believe it or not, there was a moment that I think they were a bit shocked and a little bit concerned, especially at the time when our stock price when our stock price was declining, and we tried to paint the entire picture about everything that we do contributes to shareholder value and contributes to our revenue and contributes to our cost. So in our quest to educate our employees' population, it was business. It wasn't about benefits, it was about business. How do we continue to sustain the business and offer health care at a competitive and reasonable cost that's affordable to everyone, while maintaining, of course, choice. And then we also started to think about, we're developing our strategy, and so what's ahead? What's in the next 10 years, what are we going to be faced with? And this was this was thinking back in the year 2000. So we were talking about the designer types of drugs, all of the blockbuster drugs in the marketplace today and have been over the past decade. and then the technology that increases healthcare costs, and genetic engineering and genomics and lifestyle enhancement drugs. These are all of the things that in 2000 our costs were pretty significant. But then as we looked out 10 years, that was part of our consideration in building our strategy. It's not just what's it like today, but what's it going to be like in 10 years. So really being looking forward and looking at the additional costs and what the environment would bring. In our communications, I touched a little bit already on this. To our employees, it was tell it like it is, right? Everyone is part of this problem. We can all be part of the solution. We talked about the healthcare landscape. And then we defined the strategy and the role. So we didn't just roll out a strategy and say, here it is. We defined everyone's roles, the leadership role, the management role, and the role of the employee. And the message has to be, we're investing in our business. We're investing in you, our employees. We're investing in your health. And doing the right things is going to pay benefits, and it's part of our business sustainability. So when we rolled out our strategy, it was, as I mentioned, long-term vision, and every employee at EMC understood that it was the vision was to accelerate adoption of consumerism by helping employees and family members take better care of themselves through meaningful data, right? We promised them that every program at EMC would be very deliberate and meaningful based on data. Okay. That was a little frightening to employees initially, because once they understood that we were not we, but through a third party collecting data, some privacy issues, and there was some concerns that surfaced. But because our leadership had already weighed in, we had buy-in from our leadership, we were able to manage those concerns. So when an employee called legal, or they called my boss, or they might have called Joe Tucci's office, hey, I understand that my data is in the data repository and I don't want it there. So the message was pretty clear that this was the strategy. So that's the important thing about getting the buy-in. And then to create a connected healthcare system, and to be active in the marketplace, and to be part of creating change, and to accelerate the adoption of healthcare or consumer technologies. And so our approach, when we developed our strategy, taking everything into consideration, our guiding principles using technology and data, was to create an integrated approach with data and a technology that was a smart technology that shared the data back and forth, and it created a personalized environment for the individual, right? So now that's part of gaining some momentum for the individual to engage, because it's about them. So this integrated approach is what we proposed to our leadership. It didn't exist. We were the first to integrate this type of environment. And when we talked about it early on out in the healthcare marketplace at industry forums, there's a lot of concerns about whether or not this would work, and how employees might feel about their data being shared or being in a data repository. But as I mentioned, we worked through that. And what this environment provided us was the ability to look at the data on a regular basis and understand the health of our population. That was our business intelligence. And then to drive the right programs that are targeted to the conditions of our population, or the lifestyle behaviors. And then drive the right programs and the right messaging to help them to change their behavior and to engage much more in the chronic disease type of management. Although there are disease management programs within the health plans, and they work extremely well, but we need to reinforce that internally, right? That it's much more part of a bigger picture versus just the health plan reaching out to the employees that they want them to go into a disease management program. So a unified and cohesive strategy is absolutely what will get engagement. And then data, right? So data is at the heart of our strategy. And early on, we learned that we had fragmented data and we needed to do something different. So we did something different. Now, we asked our executives for funding for our strategy to put together this integrated approach. It does take resources, and it does take financial capital. okay? But what we promised is that we would deliver results and that we would deliver ongoing metrics. So through this environment and through our consulting partner, we were able to provide what we call a dashboard. So every quarter, our leadership receives this dashboard, and it's chock full of information. The dashboard provides 3 years of healthcare cost total, broken down by member, by health plan, by hospital or health system. So the how much employees are paying out of pocket versus what EMC is paying out of pocket. The top 10 conditions that we see within the population, the top 10 drugs, utilization of generic drugs versus brand. So all of this type of data that helps us to understand what's going on a quarterly basis within our environment. So in a strategy, in a healthcare strategy, a data strategy is extremely important, because this is what's going to drive not only the program, this is what's going to drive continued engagement and ability to measure. We also now measure the employees' wellness programs, because we have many, many types of programs, again, based on the data that we see that's relevant to our employee population. And one of the questions always from finance and our leadership is, well, how do I know things are working? How, show me what your metrics are. And so now with this data environment, we're able to measure programs as well. And then what our leadership really likes is that we can give them really quick key observations in a one page, right? So if you imagine your leadership, might be traveling, might be sitting here today next to someone, and someone says, oh, what are your healthcare costs? Oh, they're X. And he or she can pull out this dashboard and talk about it in detail, exactly what's going on in the environment. So that's getting your leadership to buy in is not an easy task, but once they do and you're able to provide value back, then it becomes an easier task. And another thing that I've learned through this process is that engage, bring to the table all of the folks that you need to support your strategy, right? Not just your leadership, but procurement, right? If you're working with your procurement, legal, because if you're doing something different, you need that, legal to be part of it. Anyone that touches anything that you do, bring them to the table, because if they are part of the process, they're going to support the process. If they're not part of the process, then you run into barriers. So in the developing of a strategy, so it was a healthcare strategy, it was not a benefit strategy, okay? It was a data strategy and an integration of technology. That was the cost containment strategy. Selling it from the top down, being smart about the healthcare marketplace, getting educated, getting involvement, telling employees like it is, getting everyone involved in creating this environment, driving a meaningful and relevant programs, and creating enthusiasm. So what does that mean at the end of 10 or 12 years? In cost containment, it means over $500 million, right? So our trend, we have programs that have been measured on an individual basis, but looking at this in total, our trend versus the healthcare, the national trend, so the delta of that is $500 million without cost shifting. Early on, I'd mentioned that we changed copays in 2004 and 2005. And that was the last time that we changed copays or deductibles. We did offer HSA, but we have very few people in that plan. So we haven't made any significant financial changes to employees. As a matter of fact, employee contributions have increased over the past 10 to 12 years in the range of 4 to 5%. And 2 years ago, it was 0%. So getting that engagement and getting employees to understand why costs are low at EMC actually creates more momentum for the population. And we tell them that we've had successful years and this is why, and these are the savings. So over $500 million in cost avoidance. Back to the original slide that we had showed our leadership the cost of doing nothing, our costs will double. Okay, so now we can proudly say that we've had cost containment. And as I wrap up, I wanted to give you a little bit of takeaways. It's difficult to sell a strategy. It's difficult to develop a strategy that's non-traditional, right? Because this was very non-traditional, and I can't stress enough the importance of getting all of your partners and collaborators together to create this environment. There's so much that they can help you with, and especially today. How many of you work with PBMs today? A lot of you, okay? You know what? Go talk to your PBM. Go talk to the leadership of your PBM and see how much they've changed. You might still think of your PBM as someone that just dispenses and processes pills. They're not, right? And how do we know that? Because we're out talking to them. We're out talking not just to our account person who brings extreme value, but we talk to their leadership. What's their vision for the next 5 years? What are they thinking about? And if you go out and you talk to your PBM, you will see, depending on the PBM, that their model is changing. That's just one example. Their model is changing to more of a healthcare company than just a dispensing company. So that's one. So go talk to them. Get your leadership together with their leadership and start to think about ways to tackle this healthcare crisis together. In Massachusetts, oh my God, the opportunities are unbelievable. And I'll tell you what, any CEO of any hospital that you called and you said, gee, I'd like to bring my leadership in, could be your executive vice president, could be your CEO, whomever that might be, just to chat with you. What's going on in the healthcare marketplace? What are your challenges, daily challenges? Do we have an opportunity as an employer to collaborate? What's our opportunity? So that's extremely important to have these discussions, because you'll learn a lot. You'll also learn that there's opportunities to collaborate and do things together. Joslin Diabetes Center was one of many that we talked to, but we were able to put together a program, a first of its kind program for EMC employees that was very intensive for diabetes management, bringing Joslin to Hopkinton, because people don't usually like to drive to Boston, right? So you got to think creatively, and again, talk to leaderships of hospital systems, health plans, anyone and everyone that's in healthcare. And that's about getting involved. Leverage data, right? Understand the data. So when you're talking to your leadership, you know exactly what you're talking about, and you have the numbers and you're crisp with the data. And of course, partner with anyone that's going to touch your strategy. And I think it's very important that you're all developing and you're all innovating and you're doing great things within your companies, is to go out and talk about them, right? And brand your company and go out and get involved. And if you're in a conversation with someone, you're talking about what you're doing at your company, it's going to be unique. Chances are it's going to be unique. So that's really important. And what does that do? It's a small world, right? So one of your executives will be somewhere and someone will say, oh yes, I was talking to so-and-so and they said X about something that you're doing, right? And that's part of the branding process of creating that credibility and creating a unified strategic long-term approach to help population health management containing healthcare costs, using different approaches than what you would traditionally use. And that concludes my talk.
Thank you, Julia. I'm Rick Saya. I'm the editor of the Worcester Business Journal. I'll be moderating the panel discussion. First, I'd like to introduce the panelists one by one. If you could please just come up. I'd like to introduce first Steve Carey, who's the Vice President of Human Resources at Polar Beverages. He has been with Polar since 1998. He's responsible for HR for 3 manufacturing plants. Polar Adirondack Beverages have a total of 1,400 employees. He's been a change agent, making progressive changes in areas of benefit administration and employee relations. He holds undergraduate and graduate degrees from Anna Maria College. Next, I'd like to introduce Jane Fontaine. the Vice President of Human Resources at Digital Federal Credit Union based in Marlboro. Since she joined the credit union last year, she has brought extensive human resources and management experience to the credit union. She earned a bachelor's degree in business administration and a Master of Science in Management from Johnson & Wales University in Providence. And she also holds a Master in Health Administration from St. Joseph's College in Standish, Maine. Next, I'd like to introduce Dave Prizik, the Senior Vice President and Chief Sales Officer at Fallon Health. He's a 22-year veteran of the health insurance industry. He lives in Worcester. Prior to joining Fallon, he held several leadership positions in healthcare organizations across the country. He holds an MBA in healthcare management from Canisius College and an undergraduate degree in marketing and management from St. Bonaventure. Finally, I'd like to call up Dr. Michael Sheehy, the acting Chief Medical Officer of Reliant Medical Group. He first began his career as a primary care physician at Reliant Medical in Leominster in 1990, later transitioned to a number of key administrative roles. He earned his medical degree from BU's School of Medicine and performed his internship and residency in internal medicine at Miriam Hospital and Brown University in Providence, Rhode Island. The panel. I'd like to turn the discussion now toward healthcare reform. So I'd like to open this to all of you. When we had a teleconference last week, we talked about the Affordable Care Act and how it has impacted business. For employers over 100 employees and soon to be over 50 employees, the ACA or Obamacare has added some nitty-gritty administrative compliance functions. Can you tell us more about that and how you, Steve and Jane, how you manage that requirement?
Well, you look at the fees, we had to file by July 31st, our fees for the previous year, so we had to get that done. The employees don't see that fee. Now we are getting the 1095 forms thrown back at us that now we have to start filing this year. So people have been asking, what are you doing? Polar, we are doing our forms in-house. We've checked around, and the cost in some cases is very high. If you can do it in-house, you might be better off, or you can have your broker help you with the 1095 forms that you have to send out. My point here is, all the information that's going on that form, they're not doing it for you. So when your employees come into your company, you have to make sure you have names, social security numbers, date of birth, address. So all this information can be printed on the form that they're going to print for you. So if you don't have the exact information in your system, you're going to be sending out incorrect information. And then we find out what we're looking at now is the 17 different codes that you're going to have to put down on the forms. There's 17 codes. Well, thank God, because our renewal is October 1st, we only have 3 months. So we'll have a code just for the first 8 months. But then if you have people coming in who have been on Mass Health, who have gotten married, then they get divorced, or if they're single, they got married. They got a married plan, or now they get subsidies. You have to make sure all those codes are correct on that form. You have to be a genius putting these forms together now. And it's not easy. So this is where your broker is going to have to come in and help. Your health insurance companies are not going to be able to help because they're not going to know what's going on within your company. So when you do these forms, you have your company do the forms, we just got to make sure we have the correct information and all the codes that are on the forms that we send out to the employee and then electronically send to the government.
As Steve said, certainly it's going to be a cumbersome and burdensome process. And again, I know we've said a lot about the broker relationship. The broker can help you. I know at DCU, I essentially have one person who does really the benefits. We are working with our HRIS technology to see if there's a way that we can store that information and have that easily available so that we can get that information out of our ultimate software system. It's not easy to understand, and that's why the broker who really is staying on top of that, as Steve had mentioned, sometimes you have to evaluate your broker relationship. When I first came to DCU, we were with a different broker, and over the course of the time that I was been there, I migrated to another one who really valued the partnership. Instead of meeting once a year to just review claims, as Steve said, it's an ongoing partnership. We're constantly in contact, and that's going to help you with this compliance issue, which is not going to be fun.
I'd like to throw this question to all of you. Here in Massachusetts, we had a head start on the rest of the nation, and did that early start help your organization prepare for the ACA, or do you see the ACA as a separate set of rules and regulations?
We've been preparing, and again, your broker has to make you aware. I was aware because I do look at things, and again, you hear from your COO, you hear from the owners, what's going on, what's happening. So when I have 5 people from the mountain and Polar asking me questions, I have to make sure I know the answers. You have to be aware, and then you have to make sure that your employees come in that line, that they can afford it, and that you don't go over 9% of their gross. So what we did, because we had certain areas where the Affordable Care Act, our employees were way over the limit, we incorporated a high deductible program. Single plan, they can do the family plan, but as long as you have the single plan available, you're okay. If you don't have it available, you should look into it. We did a high deductible single plan. You go on the single rate, and it's worked out fine. And we said, no one's going to take it. Well, we have a few employees taking it. Again, they're the 18, 19, 20-year-olds who are taking the program that say, I'm invincible, I don't need a doctor, so I just want to pay as little as I want with health care. So we've been on top of it, and I can't say enough, if you don't have a decent broker, get one.
I can't say that it really affected. I mean, certainly there can be an argument made that the Affordable Care Act has increased costs with its mandates, and some employers have used the Obamacare as a reason to increase cost or shift cost, and now with the potential of some large employers with the Cadillac tax on some of those plans, that's also given employers cause to look at their plans. But again, it's really just staying on top of things, keeping yourself educated. There's so many resources out there to keep on top of what's going on in healthcare. And I'll just give a plug for HRMA. If you're not, that's an awesome resource for you as well. And I think that, as employers, we just play a huge part in educating our staff. You don't think you're an educator, but yes, most people come to work and they just assume they have their health insurance from their employer and that's it. But we have to be an educator as well and keep our employees abreast of what's going on in the marketplace.
Dave?
Yeah, between 2006 and 2012, the Commonwealth of Massachusetts figured a lot of things out. And I think the Affordable Care Act has knocked us back a few steps. And I think it's impacted small businesses. I think it's increased the cost of small businesses. I think the feds have to kind of be more flexible with the Affordable Care Act. The governor has asked for waiver to certain aspects of the Affordable Care Act, and I think that needs to happen. Right? So if there's anything that we can do and we can kind of keep putting pressure on our legislators to push for that, we need that in this Commonwealth. We had it figured out for the most part. It wasn't, utopia, but I think we had gone through a lot of that exercise, and I think we've taken a step back.
Follow on to everybody. What's left to roll out in Obamacare in 2016 and beyond that has yet to impact you and that could pose a problem? In other words, coming landmines, or could pose a problem or could pose a benefit. What changes are coming but still in the pipeline that we really have not seen rise in a level of importance yet?
From our perspective as an industry, I think it's really that 51 to 99 marketplace that's going under a big change. There's the reporting requirements, right, that you're all aware of or will quickly become aware of on all the information that you have to submit. But again, I think what's going to happen in 2016 is that you're going to see groups in that 51 to 99 segment look for alternatives because I think that there's going to be some volatility in that pricing because of some of the impacts of the Affordable Care Act. So that's probably the biggest one from our perspective.
Anybody else want to add on this one? Okay.
I think it's just gotten to the point where the businesses have to go with the flow because we're just being designated and told to what to do, where, again, when Mass did have it right, I thought we were doing pretty well. But now, again, the added cost, the more work, and then, I don't know about you, but HR is usually a cost center. So, and your CEOs and your bosses saying, well, how come you're spending this? How come you're doing that? So it's very important that we have our fingers on the cost of our benefits, on the cost of our health insurance increases. We need to understand to be able to communicate it to our top team, our employees, but we have to communicate it properly so everybody understands. You have to communicate effectively. If we don't do that, they're not going to learn. It's going to create more headaches for us, But the educational project is very huge, especially at Polar.
A question primarily for Dave, but everybody else can jump in as well. Might some small businesses be better off moving their employees over to exchange platforms such as the Health Connector? Or how do you advise clients on when to stick with a company plan or consider going the exchange route?
Interesting question. We've not seen it in droves. You're seeing it more outside of Massachusetts, where primarily the small groups, probably the under 10s, the under 5s, that are saying, we can't afford it any longer. Right? We're gonna get out of offering an employer-sponsored plan as much as we use it for recruitment and retention, and we're gonna encourage our employees to see what's available through the exchange, through the connector in this state. So we've seen a handful of groups that have made that decision. I think probably more economic than anything. So I don't think it's a trend at this point, but it's certainly something to be aware of because that discussion is starting to happen. And it's really happening a lot across the country versus here. I think Massachusetts is a little more paternalistic because we've had the mandate since 2006. And we didn't see it happen in 2006, but a lot of things have changed. Okay, higher deductible plans have come into play. And understand, too, that in addition to the federal subsidies that are available, Massachusetts is one, if not the only state in the nation that has an additional layer of subsidies. So some of these small employers are looking at it saying, is it better for my employees to opt for a product that's on the exchange?
I want to turn it now to the administration of healthcare, the provider. And so, Mike, I wanted to ask you this one. There's been an amazing growth in the number of urgent care centers and walk-in clinics across the country, certainly right here in central Massachusetts. What's the good and the bad of that change, and how is it affecting traditional healthcare providers such as hospitals?
Yeah, you're right. We've seen this not just locally but nationally. We've always offered an urgent care service. Well, I say always, at least in the 25 years I've been part of what was Fallon Clinic and now Reliant Medical Group. We've expanded that with our first ReadyMed, probably 5 or 6 years ago, and we've built 3 others now. But prior to that, really, I think that employees or patients really had 2 choices: either the emergency room or their primary care physician's office. And with the shortage in primary care, I think we saw this big rise in emergency room use. So that, coupled with the high deductibles, where now cost matters, I think has driven, really the demand for this. So the market will be saturated soon, if it's not already. I think, the benefit to consumers is that now, they can choose where they want to get their care depending on their level of acuity. And I think as long as, they're educated consumers, they can benefit from this. Our ReadyMeds are staffed by experienced nurse practitioners, for example, to try to keep the cost of care down. So it can be 1/10 of the cost of an emergency room visit often. So it offers a much wider choice for employees and patients, which I think is a good thing.
Right. It comes back to the issue of education, though. You're talking with people who, employees who probably are used to going to the emergency room with a primary care physician, and now all of a sudden there's this new business model, but they're not used to it.
You're right. You certainly don't want somebody having a heart attack walking into, one of these urgent care centers. I mean, that's not appropriate. We have triage nurses, for example, in our group practice. They can always call, and we can appropriately direct them. So we do that quite a bit. But it does require a very educated consumer. But I think, because they have a lot of the risk now of, the expenditures, they're doing this outreach and they're learning.
Okay. Dave?
Yeah, and from a benefit design perspective, make sure that your employees are aware of the benefit differentials, because most plans will have, $100 to a few $100 copay on emergency rooms, where an urgent care center or an alternative center might be subject to a copay. So it's much more affordable. We try and encourage people. The interesting piece is going to be what's next, right? The telemedicine, right? And where that goes, and do people gravitate to that? I mean, it becomes more and more convenient. We've had a nurse triage line for years, and I got to be honest with you, like 2% of the people use it, right? I mean, we're getting a lot more pickup on the urgent care centers, but the telemedicine piece is going to be really interesting to see how that evolves. And if I can ask a question, right, I'd love to hear Mike's thoughts on that.
Yeah, in fact, I was going to respond to that. We are seeing more of our patients interested in virtual care. We've staffed up for it over the years because many of our patients are not under traditional fee-for-service payer arrangements. We take global risk on a lot of our commercial population. We have about 70,000 commercial patients under full risk contracts. So it allows us that flexibility to staff up on the telephones, providing some levels of virtual care that wouldn't be paid for in a traditional fee-for-service model. We've been able to respond, but I think not quite fast enough. We do have now telemedicine available in our dermatology department. So for patients with dermatologic problems, can't get to a dermatologist or subspecialty that's in great demand. And we're looking to expand that in other services as well. But I think that's going to be a real big emerging area.
Do you think with telemedicine it's more of a generational thing? Like, you get somebody who's over 65, they're not really used to sitting down at a laptop or some other device and, calling the doctor's office?
Yeah, I think the younger generation, not only do they want virtual type care, I think they want it right now. They don't have the patience to to wait for a call back, a phone call in 2 or 3 hours. So as provider groups, we really need to respond to that. And as many of you know, medicine has traditionally been a bit conservative, and we need to really be a lot more proactive. And we're trying to at our medical group.
I don't know, my mother's 75 years old. She got a Fitbit. I was on the phone with her for an hour the other night walking her through the wearable. But, they're interested. And I do think it's somewhat generational, but this is coming along, and it's coming along quickly. And we see it from the government program side of our business, right, where we're working with a lot of frail elders and looking at a lot of monitoring devices that are out there. I mean, it's a little bit Big Brother, to be honest with you, but I think that's what people are interested in at least learning about is that, how can you be more effective on monitoring the care when you're not in the hospital, when you're at home and things like that, and whether it's, an elder parent, an elder sister, an elder brother. So it's interesting.
And I definitely telehealth I think is generational. I talked about the millennials. I mean, everything we do now, even in the financial services, everything is mobile. That's really the generational. They don't want to go bricks and mortar. And the same thing with telehealth. I think that's the way that millennials going to. They probably really want telemother because they want somebody to be like, tell them how great they are too, right? So I have 2 millennials at home. So, but I think that is definitely the way to go. Is instant. They're used to fast. They're so comfortable with technology. At DCU, we've looked at that whole generational thing, not just in the benefits we offer, the way we train people, just everything is really a focus on the generational issue.
I agree with that. At Polar, we have a portal system now where employees can go online and look up information on health insurances and anything. We went paperless on our paychecks. It took us 2 years to finish the whole project. Employees from 18 to 40 were great. From 40 to 75, it was like pulling an elephant down the road. It was very tough. But when they finally get on and understand it, and I'm going to say the educational part, educational is key to making people comfortable going online and looking up different subjects and going in, if they want to sign on to the health insurance or anything else, they could do it.
That is another big way that patients access us through our electronic medical record. About 40% or so of our patients, I think, are now on what we call MyChart. So they can access the test results, they can email us questions and concerns, and that's also been a very large area of growth in terms of how patients want to kind of touch our services.
Question for everybody. What role should employers play in educating their staffs about choosing lower cost options such as urgent care over the emergency room?
We have, for emergency room, for a while, people would just go to the emergency room, and it was a $125 copay. So we said we need to educate people not to do this, but we also put some pain in there. We increased the emergency room copay to $250. So we also started saying, you can go to this clinic, you got a sore throat, you got the flu, you have this, go to the clinic, you'll pay $15 or $20 rather than $250. So we sent out messages, we sent out brochures, and even with our plants down south and up in New York also, we increased the emergency room copay. But we had to educate the employees. And we've seen a turnaround with now they're going to the clinics for flus or colds and coughs rather than just going to the emergency room. We always say if you're having chest pains, go to the emergency room. You don't want to fool around with that. But it is helping us contain some costs, and it's making the employee aware that, okay, I'm not going to spend $250, I'm going to spend $20. That's a lot of money.
Well, this is where data and information comes in, because by looking at the trends on your claims experience, we found at DCU a lot of our staff was going to the ER. And my prior position to this was in human resources at Marlborough Hospital. So I would often see people come into the hospital for, strep throat and sit for 3 or 4 hours. And so when we looked at our data at DCU, we really tried to educate our staff on, hey, there's these walk-in clinics. I don't know if anyone's used CVS Minute Clinic. They're great, for those types of things, and really educating them. You can save time. Ultimately, you'll save money by going to these types of clinics. So it's been pretty successful. We've been able to reduce that ER use.
Dave?
I mentioned it a little bit earlier. Part of it's our responsibility and making sure that at least our members are aware of the options that are available to them, and then the economic impact, whether something is subject to a copay or deductible, or if it's more affordable to go use in urgent care. But this is where we need the help of the employers. We send out a lot of information, and a lot of it doesn't get read. Right? And so, anytime that we can piggyback messaging, work with your insurance company. It doesn't necessarily just have to be Fallon. If you're concerned about that and you want to look at your utilization, work with your insurance carrier, work with your broker, and make sure your employees understand the benefits that are available to them. Anything that employers can do to help drive that engagement rate, I think, is going to help us all.
Mike?
We actually have a nurse call most of the patients that have gone to an emergency room just to check in with them, make sure they're doing well and whether or not they need a follow-up appointment. But more than that, to educate them. If it was a lower level issue that we could have taken care of, we like to remind them of that. We also do outreach. We do a lot of data mining and do a lot of population health data analysis and look at our frequent flyer lists of patients that go to the emergency room routinely and do a lot of outreach to them as well, which has been very effective.
Final question. I'll direct this primarily at Dave and Mike. We all read about the announcements of some huge mergers in the health insurance field, such as Anthem's planned purchase of Cigna and Aetna's merger with Humana. What do these consolidations mean to you and the small business audience, and what does the further consolidation of medical practices, such as Reliant and Southborough, mean to Reliant and its patients?
Sure. So from the provider side, many provider groups are not large enough to manage what we're calling payment reform or managing patients under risk contracts or with capitation. So it really, the mergers do allow, leverage larger amounts of resources. We built a lot of infrastructure, much like a health plan, to really manage risk. And in order to do that effectively, you really need a larger patient population. So I think that's one area that provider groups merging really can tap into, as we get away from this fee-for-service medicine. You can be a one-doc shop and deal with fee-for-service medicine, but you can't do that, dealing with risk contracts or payment reform.
Dave?
Yeah, there's a lot of activity nationally with some fairly sizable mergers that are going on. I don't know the direct impact in Massachusetts. I mean, it seems to be more of a national issue at this point. Selfishly, I hope they get distracted with that and it creates opportunity for Fallon. But the bigger observation that we have is more the provider consolidation and the broker consolidation. Right? That's happening, and that's happening at a rapid pace right now. And I think it's great when Reliant comes together with Southborough Medical Group because, again, it leads to more efficient delivery of care, more affordable, probably higher quality care that we can help drive people to and hopefully help provide a more cost-effective product. And then we saw kind of the other end of that, where the Attorney General got involved last year with the partners arrangement and basically stopped them from acquiring South Shore Hospital because I think it got to that tipping point where when you get that big, the leverage that's put on us as an insurance company and employers on the cost of healthcare gets a little bit too much. So it's striking that fine balance because, and again, interested in Mike's opinion on whether or not independent physicians can even survive, okay, in a risk-based environment when we're asking for more coordinated care, and that's getting pushed at the federal level and at the state level. So we'll probably see more of that. And then again, on the brokerage side, you're seeing brokers consolidate rapidly. And that's because the services that's demanded from the brokers and consultants is expanding. The wellness, the compliance, all those sorts of things, they're coming together to be able to provide those services, which means their blocks of business with folks like Fallon get really, really big. And again, it exerts a certain amount of leverage. So there are certainly things that we're paying attention to.
Mike, what about the independent physicians?
Yeah, I think that I think you're going to see a lot more partnering up. It's challenging for them even to get an electronic medical record in place, and to comply with meaningful use. But to deal with payment reform and risk-based contracts is a whole order of magnitude different in terms of the infrastructure, just the data needs. And again, to deal with global risk, I mean, you really you've got to have, cash reserves. You've got to have the ability to do, actuarial work on these populations of patients, and, very robust data mining that, small physician shops just can't do.
Well, thank you very much for all the insight. Nice work.